This is a 62-year-old male that's been admitted to the hospital for fever and chills over the last 2 days. He has had an influenza swab and we're waiting for results. He is awake, but he's been very drowsy. Hey, sir. How are you? My name's Eric. I'm going to be your nurse today. How are you feeling? A little sleepy? Your heart rate's going fast. Can you feel it? A little bit? Okay. So your heart rate right now is 175, which is pretty fast. So I'm just going to go ahead and get ready and call my team in to help me out here, okay? Team, if I could have you come on in. Okay. With his heart rate being this high, I'd like you to go ahead and get him on the heart monitor. Daniel, his oxygen is 89-90, so we can go ahead and put him on some nasal cannula oxygen. We could start at 4 liters just because his heart rate's very high. Blood pressure is 100/80. It's normal on the lower range of normal, but it is normal. So I'm going to ask you a couple questions, okay? Amber, can you also go ahead and get an IV established for me? Sir, do you have any chest pain right now? No? Okay. Do you have any history of heart failure? No? Okay. You're not coughing up any pink frothy sputum? All right. And then have you taken any medication today that I need to be aware of? Sometimes medication can make your heart rate go up. Okay. Since this is SVT, it looks like on the monitor, I'm going to go ahead and get an EKG, have the EKG people come in when they get here, okay? So the first thing I'm going to have you do, okay, is I'm actually going to have you bear down a little bit, almost like you're having a bowel movement. It sounds really strange, but what that does is kind of help lower your heart rate a little bit. So go ahead and like bear down for me, okay? While you're doing that, Amber, can you prepare adenosine 6 milligrams, please? Okay, I know that was weird. Did that help at all? You feel the same? Okay, your heart rate's still high a little bit, so we're going to give you some medicine now. Okay, we're going to give adenosine 6 milligrams, a rapid IV push, followed by a 20 ml saline flush. So this medicine she's going to give you is going to make you feel kind of strange. Okay, it's going to make you feel dizzy, lightheaded, but that's going to pass very quickly, okay?
All right. 6 milligrams. Flush completed. 6 milligrams of adenosine. Flush completed.
Okay. I know that was scary. Okay. So that medicine works very quickly, and it looks like we're still in this high heart rate of 176. Okay. We're still in a stable tachycardia, but we need to keep addressing this. So we're going to do the same medicine again. I'm sorry, but we're going to give adenosine 12 milligrams IV push, followed by a rapid flush. I said that wrong, Amber. I'm sorry. We're going to give adenosine 12 milligrams rapid IV push with a 20 ml flush. Another funny feeling, sir.
All right, 12 milligrams of adenosine in, followed by 20 cc flush.
All right. Dawn, do you mind recycling the blood pressure for me? Sir, how are you feeling? Sir? Sir, are you still with us? Feeling a little drowsy? All right. My heart rate is still very high. I'm still in SVT, a narrow complex, narrow QRS complex, still regular, but now we're symptomatic. His altered mental status now, he's a little drowsy, and his blood pressure is low at 83/52. So we're going to treat this as unstable tachycardia. So we're going to do synchronized cardioversion. Okay. So we're going to get the patient on the pads, okay? If available, we're going to give sedation for this patient, so to reduce some of the pain. So we're going to turn the machine, dissolve to 50, to defibrillate. Okay, we're going to make sure our sync button is pressed, and when that's pressed, we should see a dot over each QRS complex. Excellent. When that's confirmed, we can charge to 100 joules.
100 joules.
Yep, and then we
100
can administer that electricity when you're ready, clearing the patient. Okay, going to charge to 100 joules. Everyone clear?
Everyone clear?
Clear.
Shock. Shock delivered.
Okay. Sir, how are you feeling? All right. Looks like he's not responding to us anymore. I'm going to check a pulse. I no longer have a pulse. Let's begin CPR, please. Daniel, I'm going to have you do airway. You with the ambu bag. Dawn, I'm going to have you start CPR after we get the backboard underneath the patient. When we begin our compressions, we're going to do 30 compressions to 2 breaths. We're going to do a 2-inch compression and allow for good chest recoil. Okay. As this is going, this is a shockable rhythm. So we're going to defibrillate this patient at 200 joules. So we can go ahead and charge that.
200 joules, charging.
Okay. Deliver the shock when it's ready.
Please step away. I'm clear. You're clear. Everyone clear. Delivering shock.
Resume CPR, please. Amber, if you could get ready 1 milligram of epinephrine for our next medication dose. Okay. Okay. If we could press a little bit harder on our compressions. Good. We're looking for about 100 compressions per minute. Very good. Okay. It's been about 2 minutes since our last pulse check. I'm going to pause. The rhythm has not changed. I'm still pulseless. Let's resume CPR. Okay. This is still a shockable rhythm in ventricular fibrillation. So let's go ahead and deliver 200 joules. Defibrillation, let's shock at 200 joules.
All right. Charging. Everyone step away. I'm clear. You're clear. All clear. Delivering shock.
Resume CPR. Okay, we're going to deliver that medication now. We're going to deliver epinephrine 1 milligram IV push. Epinephrine can be given every 3 to 5 minutes. There is no max dose for this.
All right, 1 milligram epi in, followed by flush.
Okay. Our next dose of medication is going to be amiodarone 300 milligrams, if you want to go ahead and prepare that. Okay. We're ensuring we're doing CPR, still good quality chest compressions, 30 to 2 breaths. Okay. If either one of you are tired, you can rotate your jobs at the next pulse check.
Please confirm 300 milligrams.
Amiodarone 300 milligrams, please prepare it. That'll be our next medication. On our chest compressions, let's make sure we're doing right over the mediastinum. Okay. Okay, we're going to pause compressions for a pulse check. Patient remains in ventricular fibrillation. There is no pulse. Let's resume CPR. We're going to defibrillate, we're going to shock the patient at 200 joules, which is the max for our machine.
All right. Charge, step away. I'm clear. You're clear. Delivering shock.
Okay. Resume CPR. Amber, if you could please administer amiodarone 300 milligrams IV.
6 mLs, 300 milligrams, delivered, followed by saline, flush.
Can you confirm the medication you just gave?
Amiodarone.
Thank you. Our next dose of medication will be epinephrine 1 milligram if you want to prepare that. Okay, it's been 2 minutes since our last pulse check. Hold CPR. Patient remains in ventricular fibrillation with no pulse. Resume CPR. We're going to defibrillate the patient at 200 joules, which is our max for this machine. So please defibrillate or shock when ready.
Okay, charge ready, step away. I'm clear, you're clear. Shock delivered.
Resume CPR. Remember, if we can deliver that or administer epinephrine 1 milligram that you have prepared.
Epinephrine, 1 milligram, followed by flush. Completed.
Thank you. Our next medication is going to be amiodarone 150 milligrams, if you'd like to prepare that. We're going to continue the CPR and let that medication circulate. We're doing great on our chest compressions and our oxygenation. Please feel free to switch whenever you're tired.
Please confirm dose of amiodarone.
Amiodarone 150 milligrams
Okay.
IV, which should be 3 mLs.
Got it. Ready when needed.
We're going to pause for a pulse check. Checking for moral pulse. There is no pulse. The patient remains in ventricular fibrillation. Let's resume CPR. We're going to shock the patient, defibrillate at 200 joules, which is the max for this machine. Please defibrillate when ready.
Please step away. Fully charged. I'm clear, you're clear, all clear. Shock delivered.
Resume CPR, please. Okay, and can we administer amiodarone 150 milligrams IV push, please?
Amiodarone, 150 milligrams, which is 3 mLs, IV push, delivered, followed by flush.
At this time, we're going to start looking at possible causes for this patient to remain in ventricular fibrillation. This is known as the H's and T's. So this could be hypovolemia, hypoxia, hyperkalemia, hypokalemia, hypothermia, or hydrogen ions, which is an acid-base imbalance. There's a possibility of tamponade, cardiac tamponade rather, pneumothorax, toxins or medications or drugs or bacteria that could be causing this. And then finally it could be a pneumothorax. It's a very good possibility this patient has a toxin related to infection, so we're going to see how that comes back for us. And in the meantime, we are going to do a pulse check because it's been 2 minutes. Okay, patient remains in ventricular fibrillation with no pulse. Resume CPR. We are going to defibrillate at 200 joules.
Charge to 200, step away. I'm clear, you're clear.
Clear.
Shock delivered.
Resume CPR. It's been 3 to 5 minutes since our last dose. Let's give another dose of epinephrine, 1 milligram, IV push. Okay. As we're giving this epinephrine, we have used all of the amiodarone that we can use for this cycle.
Epinephrine, 1 milligram, IV push,
Thank you.
given, followed by saline flush.
We're going to continue to CPR to our 2-minute pulse check. Okay, we're going to pause for a pulse check. It's been 2 minutes. It feels like I'm starting to get a pulse back, so I'm going to check the monitor. I am confirming. Let's try to see if we can get a blood pressure as well. I do feel a pulse, so we'll have the monitor catch up for us. And if I feel a pulse, it looks like we are in ROSC, which is return of spontaneous circulation. And so while we're in ROSC, we are going to have you confirm an advanced airway and maintain breathing for this patient. We can contact respiratory therapy as needed. We're going to get an EKG for this patient as needed, and we are going to, since he's, sorry, how you doing? not responsive to us, he's a good candidate possibly for targeted temperature management. We could do labs and a chest x-ray accordingly and then get the patient transferred to definitive care or the critical care unit as needed. Thank you all.